So coming to the properties of cardiac muscle. The properties of cardiac muscles are physical property, electrical property, mechanical properties, and metabolic properties. Coming to the electrical property, in electrical property there is
Doctor, please.
Yeah.
Can you share the slide fully? Okay.
Is it okay?
Okay.
Okay. So the properties of electrical properties, that is autorhythmicity, excitability, and conductivity. The mechanical properties are contractility, all or none law, staircase phenomena, and the refractory period. And there are metabolic properties. Coming to the physical properties, the cardiac muscles are involuntary in nature. They are branched and the size of around 18 micrometer length and around 15 micrometer in breadth. And intercalated discs are present and gap junctions are present that we have seen. What are they? And it acts as a syncytia, that it functions as a single unit because of the presence of gap junction. The nucleus is centrally located. And triads are present at the Z line, and the cardiac muscles are having long refractory period, and the conducting system, a specialized system known as the conducting system is present in the cardiac muscle. Coming to the autorhythmicity, electrical property, the autorhythmicity. All the cells of the heart have an inherent ability to generate impulses. So, SA node is known as the pacemaker of heart. That is the rate of impulse generation in SA node is around 70 to 80 beats per minute. AB node is 40 to 60 beats per minute, and the Purkinje fibers is around 15 to 40 beats per minute. From this, we can see that all the specialized nerves, muscle cells are able to produce the impulses. But the SA node produces the impulses much more comparing to other areas. So that's why we can consider the SA node as the pacemaker of heart. If this SA node is not properly functioning, AV node take up the charge. So the action potential in the SA node will looks like this, and let's see in detail. The resting membrane potential of SA node is around minus 60 millivolt. That of the contractile cardiac fiber, the other fibers, is around minus 90 millivolt. And this resting membrane potential is unstable. And this unstable resting membrane potential, when we record it, it can have a prepotential, a spike, and a repolarization phase. So the prepotential or pacemaker potential. Prepotential or pacemaker potential is due to the slow entry of sodium ions because of the calcium influx through transient or T-type of calcium channels. And that's why the RMP is very unstable. It changes from 60 millivolt towards positivity. And the depolarization is a spike potential, starts at threshold potential of minus 40 millivolt due to the opening of voltage gated calcium channels or L-type or long-standing calcium channels. First, T-type transient calcium channels are opening, then L-type calcium channel are opening. So the potential peaks to around 20 millivolt. And coming to the repolarization is due to the closure of calcium channels and opening of potassium channels. So the significance of prepotential is that it is the characteristic of tissues with automaticity, and it is prominent in SA node and AV node, and the alteration in prepotential will alter the rate of impulse generation. That means if there is a alteration, like if there is nothing, no neural impulses, or no, there is no other chemical impulses, we can get the pacemaker potential like this. But if we have stimulated the sympathetic nerve, the sympathetic nerve stimulation will reduce the pacemaker potential, so the rate of impulse generation is faster. And coming to the parasympathetic nerve stimulation, there is longer pacemaker potentials. So we will get the rate of impulses much slower, less rates will be produced. So the factors affecting autorhythmicity: autonomic nerve stimulation, the vagal stimulation decreases the slope of prepotential and reduces the rate of impulse generation. And sympathetic stimulation increases the slope and increases the impulse rate. Also, temperature, hormones, and some drugs and ions are also affects the autorhythmicity of the cardiac muscle. And coming to the excitability, the ability of a tissue to give response to a stimulus is known as excitability. Resting membrane potential of a cardiac muscle is around 85 to 95 millivolt. SA node depends on around 55 to 60 millivolt, and the Purkinje fibers is around 90 to 100 millivolt. So the excitability which shows the change in potential when it gets stimulated. So we have seen about the chronaxy and all. So the for cardiac muscle, it is 3 to 30 milliseconds. So the phases of excitation or the cardiac action potential is depolarization, initial repolarization, a plateau level, and the final repolarization. Let's see the diagram. Here, coming in comparison with the other action potential, here we can see a difference. That means there is a plateau phase. No other action potential in the body shows this plateau phase except cardiac muscles. And smooth muscles, sometimes it may show, but we can't able to say it is permanent. But in cardiac muscle, this is the prominent feature in the cardiac muscle. So let's see the action potential in various cardiac muscles, the SA node and the ventricular musculature. The action potential, the shape changes. So in a nutshell, we can see that the resting membrane potential is minus 90 millivolt, and the phase 0 or the 0 phase is the rapid influx of sodium, rising membrane potential to 20 millivolt. Phase 1 is the initial repolarization, which causes the closure of sodium channels. This phase. A notch is present here. And phase 2 is the plateau, which causes the opening of L-type calcium channels, long-lasting calcium channels. And phase 3 is the repolarization phase, where closure of calcium channel and opening of the potassium channels happens. And in the phase 4, there is the resting membrane potential attained. Coming to the depolarization. The depolarization phase is very rapid, that's around 2 milliseconds. Amplitude is around 20 millivolt, and that is due to the rapid opening of fast sodium channels and rapid influx of sodium ions. The drug tetrodotoxin that blocks the sodium channel, so it blocks the influx of sodium ions, so there is no excitation, causes no contraction of the cardiac musculature. An initial repolarization, that is a notch phase, that is because of the closure of sodium channel and calcium influx. Sorry, instead of chlorine, we have to say it is calcium. And there is slow increase in the potassium permeability. And muscle fiber remains in the depolarized state for some time before repolarization. That is the plateau phase. That is around 0.2 to 0.3 seconds. And the contraction phase is longer because of this plateau phase. And this is because opening of slow calcium channel, slow influx of sodium channels, and which balances the potassium efflux. The positivity is maintained and produce prolonged depolarization. And coming to the final repolarization, this is a slow process. Duration is around 0.5 to 0.8 seconds. That is due to the efflux of potassium ions. And the RMP, or the resting membrane potential, is restored by the sodium potassium pump. That means the sodium ions move out and potassium ions are pumped in, and calcium ion move out by the sodium calcium pump. Next property is contractility, that is the ability to respond to an impulse by contraction, mainly exhibited by the atrial and ventricular muscle. Coming to the conducting system, the SA node is the flat, small, flattened and ellipsoid strip of specialized muscle which is situated in the right atrium, the superior vena cava. And they are known as the pacemaker of heart, which is having pace cells, which are primitive cells, which are rhythm generators. And next, coming to the internodal pathway, which connect SA node and AV node. They are having faster rate of conduction than atrial muscles. There are three group of muscles. They are anterior, middle and posterior. Anterior musculature is backman, middle is Wenke back, and posterior is thoral. This is the structure of the conducting system. Coming to the AV node, this is the only conducting pathway between the atria and the ventricles, which is situated in the posterior septal wall of the right atrium behind the tricuspid valve, which causes conduction delay. The velocity of conduction in this area is around 0.05 meter per second. And because the delay is around 0.13 second, that is around 0.09 at AV node and 0.04 at AV bundle between. So the delay is due to the smaller size of fibers are present in the AV node, and there are smaller number of gap junctions are present and multiple branching system in the AV node. We have seen that in the first itself, I have told you that there was a atrioventricular fibrous ring is present. This atrioventricular fibrous ring, that fibrous ring is having smaller size of fibers and smaller number of gap junctions. That's why this AV nodal delay from the atria to the ventricle, there is a delay. So the importance of this evidonal delay is atria contracts around 0.1 second earlier than ventricle, and also which limit the number of impulses transmitted to the ventricle, that is less than 230 per minute. So because of this delay, we can say that it accesses syncytia, atria and ventricle. Separately, it is contracting. And coming to the bundle of hairs, it begins from the AV node, passes downwards in the interventricular septum, and which divides into right and left bundle branches. And this right and left bundle branches divide repeatedly and lie subendocardially. And coming to the Purkinje fibers, these Purkinje fibers takes origin from terminal divisions of bundle branches, and they are the fastest conducting fibers, which passes impulses to the ventricular myocytes, and the direction of impulse conduction is always from endocardium to epicardium. See here, this is the origin and spread of the impulses in a flow chart, that is from SA node, atrial, the bundles, through the bundle it goes to the AV node, and AV node to bundle of his, right and left bundle branches, Purkinje fibers, and the ventricular musculature. And the conducting rate in each part of the cardiac cell is atrial muscle is 0.3, internodal tract is around 1 meter per second, AV node it is 0.05 meter per second, Purkinje fibers is faster around 1.5 to 4, and in the ventricular muscle it is 1 meter per second. Coming to the mechanical properties, the first mechanical property is contractility. We have seen a small slide earlier. Let's see in detail. That is the ability of the tissue to shorten in length after receiving a stimulus. So, that is the excitation contraction coupling of the cardiac muscle is almost similar to that of skeletal muscle, which depends on more of the extracellular fluid calcium concentration. So here the action potential, which causes the opening of voltage gated calcium channels in the T-tubule, and DHP receptor or dihydropyridine receptor acts as a sensor and trigger, which causes the opening of ryanodine canals in the terminal cisternae, causes calcium into the sarcoplasm, causes muscle contraction. So there are load on the contraction. What will happen to the load? Preload, that is the load acting on the heart before it starts contracting. That means the load acting on the cardiac musculature before it starts contracting is known as preload, and afterload is the load acting on the cardiac muscle after it starts contracting. So that is the resistance. So preload we can say is the end diastolic volume, means how much blood is inside the heart and how much it got expanded before the contraction. And afterload means the resistance offered by the blood vessels. How much resistance is offered and how much forcefully our heart has to pump to overcome that resistance. That is the afterload. Frank Starling law states that the force of contraction is proportional to the initial length of muscle within the physiological limit, and initial length depending on the preload, that is the end diastolic volume. And next property is all or none load. That means when a stimulus is applied, whatever may be the strength, the whole cardiac muscle responds to the maximum, or it doesn't give a response at all. And this is applicable for all cardiac muscle. That is, the action potential fails to occur if the stimulus is in subthreshold magnitude and it occurs with constant amplitude and form regardless of the strength of the stimulus, if the stimulus is at or above the threshold. So, the next property is staircase phenomena or trippy. After a brief rest, on stimulation at regular frequency, the force of contraction increases progressively to a maximum, then it maintained a plateau. So, we are giving small threshold contractions. We will get a maximum response and that will maintain for a longer period. This is because increased accumulation of calcium, increased temperature, and reduced viscosity due to continuous stimulations. Next, coming to the refractory period. That is the duration during which an excitable tissue will not respond to a second stimulus. Here, there are two types of refractory periods are present, an absolute refractory period and relative refractory period. Absolute refractory period means the period during which the muscle doesn't show any response at all, whatever may be the strength of the stimulus. And in the relative refractory period, the muscle shows response if the strength of the stimulus is increased to the maximum. And the cardiac refractory period is having long refractory period. Absolute refractory period is around 250 milliseconds and the relative refractory period is around 50 milliseconds. So, and the refractory period of atria around 150 milliseconds. So, the importance of this long refractory period is the cardiac muscles won't get tetanized and not get fatigue, because we can see the whole cardiac muscle contraction, whole of the action potential, whole of the muscle contraction takes around 250 to 300 milliseconds, depending on the impulse production. The whole of muscle contraction takes around 250 to 300 milliseconds. In that, a long part is in absolute refractory period point and a minor part is in the relative refractory period point. So there is no chance for a second stimulus. No chance means there is a very rare chance for a second stimulus to produce a response. That's why it is saying the cardiac muscles are non-fatigable and non-tetanizable. See the difference. And coming to the metabolic properties, the high blood supply, the cardiac muscles are having high blood supply of around 80 ml per 100 gram per minute and which work under aerobic conditions. And numerous mitochondria are present in the cardiac muscle and which contain high amount of myoglobin. Myoglobin, that is the protein which just like hemoglobin, which help in the storage of oxygen and which is present in the most working muscles. And the calorie need of heart are provided by 60% of fats, 35% of carbohydrates, and around 5% of amino acids. Just take a small difference between the cardiac and skeletal muscle. The cardiac muscles we have seen. Coming to the skeletal muscle, they are voluntary in nature. They are not branched. There are the absence of intercalated disc and a gap junction, and individual muscle fiber will contract in skeletal muscle. It's no incisure or a unit is present. The eccentrically located multinucleus is present in skeletal muscle. Triads are present at the AI junction, and which is having a short refractory period. That's why the skeletal muscles are getting fatigued easily. And there is no conduction system. There is no separate conduction system is present. So this is the structure of cardiac muscle, smooth muscle, and the skeletal muscle. Thank you.